The Washington Manual of Surgery podcast is based on the 9th edition of the best-selling Washington Manual of Surgery.
This podcast is meant to condense key topics from our manual into bite-sized episodes for your convenience. Now, on to this installment of the Washington Manual of Surgery podcast.
Hello, everyone, and welcome to the Washington Manual of Surgery podcast. We bring you everything you need to know about high-yield general surgery topics built for your just-in-time learning. On this episode, we are thrilled to have Dr. Grace Niziolek here to review management of all things chest trauma. Dr. Niziolek is a trauma surgeon at Washington University in St. Louis, and my name is Hannah Phelps. I'm a surgery resident, and I will be your host for this episode.
Hey, Hannah. Happy to be here. Thanks for having me.
Thanks for coming. Chest trauma is ubiquitous and therefore a highly relevant topic to the general surgeon. Thoracic injuries occur in 20 to 25% of all traumas and may contribute to as many as 75% of trauma-related deaths. Let's dive right into a case scenario to guide our discussion. You receive a level 1 page with the following information. 28-year-old male with gunshot wound to the left chest, blood pressure 82/46, heart rate 133, ETA 8 minutes. Let's first take a moment to review pertinent anatomy in the chest, since this will help us anticipate potential injuries we may encounter. Dr. Niziolek, what specific anatomy are you considering when you encounter a patient as described in our scenario?
Great case to start with. Whenever I'm walking down to the trauma bay, especially for penetrating trauma cases, I find that I actually remind myself of the anatomy that might be involved, and it really helps me to think through what might be happening and what might need to be done. The chest houses several critical organs and structures that we need to consider in a patient presenting with chest trauma. These include the heart and the pericardium. The heart is obviously a mediastinal structure with left and right ventricles facing anteriorly, making these the most commonly injured chambers. The pericardium is a thin membranous sac composed of parietal and visceral layers with an intervening potential space. And it's this potential space that can allow for pooling of fluid, which combined with the pericardium's restrictive nature is what can cause cardiac tamponade. There are two important nerves to consider in this area. The phrenic nerve runs along the lateral aspect of the pericardium, which is why you incise the pericardium longitudinally. And the vagus nerve runs posterior to the pericardium and lung root. The lungs and pleura are obviously in the chest as well. The parietal pleura lines the chest wall, and the visceral pleura covers the lungs. Between these layers, there's another potential space, again, where fluid or air can accumulate and potentially cause tension physiology. And as a reminder, the right lung has 3 lobes and the left lung has 2 lobes. In the mediastinum, there are many important structures, including the tracheobronchial tree. The trachea enters the thoracic inlet down to the carina, which is located around vertebral body T4, where it splints into the right and left main stem bronchi. One of the tip-offs that you might have a major bronchial injury is a large blowing air leak and worsening gas exchange following chest tube placement. The esophagus is also in the mediastinum and is composed of 4 segments based on blood supply: the cervical, upper thoracic, mid-thoracic, and lower abdominal esophagus. Additionally, the mediastinum includes the great vessels, which are the aorta, main pulmonary artery, pulmonary veins, superior vena cava, and inferior vena cava. And finally, you always need to consider the chest wall and diaphragm. The chest wall is made up of 12 ribs. The neurovascular bundle runs inferior to the ribs, which is important to remember when placing chest tubes. 3 major diaphragmatic foramina allow for passage of key structures: the IVC at T8, the esophagus at T10, and the aorta at T12.
Great review. Now let's focus back on our specific trauma patient. What are some of the things you would like to know on history and physical? Is there anything in particular you would want to have on hand in preparation for this trauma activation?
As with any trauma patient, ATLS protocols should be followed. Airway, breathing, circulation, I'm sure you all know this at this point. For airway, we want to be prepared to intubate or perform a surgical airway if endotracheal intubation isn't feasible. For breathing, we're listening for the absence of breath sounds. We would want to be prepared to perform a needle or finger decompression and placement of a chest tube. For circulation in a hypotensive patient with chest trauma, we really want to prioritize obtaining access quickly, ideally with at least 2 large bore IVs, and we'll want to have uncross-matched blood products available. And this is a patient that would meet most trauma centers' criteria for activating massive transfusion protocol. We will also want to have a thoracotomy tray readily available. On secondary survey, we'll assess for chest wall crepitus, contusions, flail segments, and for scars from prior thoracic procedures. For a penetrating injury, we'll pay careful attention to the location and number of ballistic wounds, which could help indicate a trajectory. As for adjuncts to the primary and secondary survey, the patient should undergo a chest x-ray, which can help identify life-threatening injuries in need of immediate intervention. With a blunt mechanism or a thoracoabdominal penetrating injury, you can also consider the use of FAST or EFAST.
So you mentioned 2 key trauma procedures there, and I'm hoping to spend some time reviewing those procedures. When I was an intern, one of our chief residents told me there are really only 3 procedures you must be able to do off the top of your head as a surgery resident, and everything else you have time to look up. And those procedures were first, central access, second, chest tube placement, and third, a resuscitative thoracotomy. So first, can we briefly review the key steps of chest tube placement?
In the context of chest trauma, tube thoracostomy is indicated for pneumothorax or hemothorax. The patient should be positioned supine with the arm raised above the head. The chest tube should be placed in the 4th or 5th intercostal space in the mid-axillary line. For men, this is generally at the level of the nipple, and for women, this is usually at the inframammary fold. If there's time and the patient is awake, you can inject a local anesthetic. You then make an incision at your pre-identified landmarks and divide subcutaneous and muscular tissue to the level of the chest wall. Next, enter the pleural space bluntly and superior to the rib to avoid injury to the neurovascular bundle. Then perform a finger sweep to confirm entry into the chest cavity and assess for any adhesions. You're going to clamp the chest tube on both ends and advance with the insertion ends superiorly and inferiorly into the chest cavity, ensuring that the sentinel drainage hole is within the chest cavity. And this is usually at the 10 to 12 centimeter mark in most adults. Use an anchoring stitch to affix the chest tube and place an occlusive dressing. Make sure you connect the tube to your drainage device, and usually you'll want to apply minus 20 millimeters of mercury of suction. You'll always want to obtain a chest x-ray to confirm tube placement and resolution of the pneumo or hemothorax.
Great, thank you. Let's talk about what type of chest tubes to place. There is some new data to suggest that large bore chest tubes may not always be the answer. So I'm interested to hear your approach to chest tube selection.
So traditional teaching called for a 36 to a 38 French tube for hemopneumothorax in adults. It's a pretty big tube. However, recent data shows no difference in outcomes with smaller tubes or even pigtail catheters. I personally tend to grab a 28 French or smaller tube when available. And I also think ultrasound-guided pigtails are a good option in the hemodynamically stable patient.
And my attendings frequently remind me that I cannot just place a chest tube and walk away. So what sort of parameters are we looking at in the first few hours after chest tube placement?
Yeah, it's definitely important to monitor chest tube output. In general, if the initial output is greater than 1.5 liters, or if the output is greater than 200 milliliters per hour for 4 hours, we need to consider that you don't have hemorrhage control. In an unstable patient with high output, proceeding to the operating room for thoracotomy is generally the right answer. If the patient is stable, you may be able to start with a CTA and consider angioembolization versus surgical intervention.
And once we've made the decision to enter the chest, we also need to think about how we are going to enter the chest. So how do you choose which incision to make?
Choosing your incision should be guided by what structures you think are involved. In general, severe bleeding from either lung can be controlled by either a left or a right thoracotomy. A bit more thought needs to be given to the mediastinal structures, though. The proximal right carotid is best accessed via a median sternotomy, which can be extended up the neck if more distal control is needed. The proximal left carotid is best accessed via a high left anterolateral thoracotomy, and if distal control is needed, a left neck incision can be made. Subclavian injuries should be considered for endovascular repair. However, if the patient's unstable and continues to hemorrhage, the proximal right subclavian is best accessed with a median sternotomy, and the proximal left subclavian is best accessed with a high left anterolateral incision. More distal control for either subclavian can be done through a supraclavicular incision on the injured side. A median sternotomy is a good option for cardiac injuries and great vessel injuries. Posterior mediastinal structures such as the esophagus and descending aorta usually need to be accessed through a right or left thoracotomy.
That's a great review. Very important for taking care of patients and also a classic ABSITE question. So when looking for cardiac injuries, how do you decide if you're going to do a pericardial window or go straight to a median sternotomy?
The pericardial window is a great option for the hemodynamically stable patient who could have a cardiac injury, but you have a low suspicion for. It's important to remember that a pericardial window is more of a diagnostic test, not a solution to a problem. You can't fix a cardiac injury through the window, and if you confirm a cardiac injury with a window, then you'll need to proceed with a median sternotomy. We most commonly do these during abdominal exploration for trauma to rule out a cardiac injury. If you have an imaging study showing a cardiac injury, then a window is not needed and you should proceed directly to a median sternotomy. Similarly, if a patient is hemodynamically unstable and you have a high concern for a cardiac injury, for example, a stab wound to the box, then proceed immediately to median sternotomy.
Okay, so now for the topic we've all been waiting for, the resuscitative thoracotomy or ED thoracotomy. Despite being a resident at a high-volume trauma center, I can count on one hand the number of ED thoracotomies I've participated in. So since this is something that many residents do not get a lot of experience with, perhaps we can discuss the indications and basic steps for the resuscitative thoracotomy.
Yeah, this can be a confusing topic for residents and medical students, partly because even experienced trauma surgeons don't completely agree on indications for ED thoracotomy. The paper referenced in the Washington Manual chapter is from the Western Trauma Association. They performed a large prospective multi-center study aimed at identifying injury patterns and physiologic profiles compatible with survival after ED thoracotomy. They concluded that this procedure can be considered futile in the following patients: those suffering blunt trauma with greater than 10 minutes of pre-hospital CPR without signs of life on arrival, patients suffering penetrating trauma with greater than 15 minutes of CPR without signs of life on arrival, and patients in asystole on arrival to the emergency department without evidence of tamponade. To be clear, those three criteria should help you determine who definitely should not get an ED thoracotomy. So here's who should get an ED thoracotomy, or at least should be considered for one. Penetrating trauma patients with less than 15 minutes of pre-hospital CPR, and blunt trauma patients who lose pulses in the trauma bay or who show signs of life or have cardiac activity on ultrasound if pulses were lost within 10 minutes of arrival to the emergency department. As for the procedure itself, a left anterior thoracotomy is performed in the 5th or 6th intercostal space with sharp division of the skin, subcutaneous tissue, and intercostal muscles from the sternum, curving up towards the axilla with the incision taken all the way down to the bed. A Finicetto retractor is placed to spread the ribs and aid in exposure. The pericardium is identified and incised vertically and anterior to the phrenic nerve. Any clot or debris is removed from the pericardial sac, and the heart is inspected for injury. If a cardiac injury is identified, a damage control repair is performed. Simultaneously, the patient should be undergoing aggressive volume resuscitation. If peripheral vascular access is insufficient, direct infusion into the right atrium can be performed. During volume resuscitation, open cardiac massage is continued to provide adequate circulation. And in severely hypovolemic patients, the descending thoracic aorta may be exposed and cross-clamped to maintain coronary and cerebral perfusion. The aorta should also be clamped if any intra-abdominal hemorrhage is suspected. After restoration of circulatory volume, the underlying rhythm is assessed and internal cardioversion can be used if the heart is fibrillating. After successful resuscitation, the patient should be transported to the operating room for definitive repair.
Great, thank you for that summary. Shifting gears a little bit, there are a lot of potential complications when it comes to chest trauma, and we don't have time to address all of them, but there are a couple that I'm hoping to discuss because these can be difficult problems to manage. First, what is your general approach to a retained hemothorax?
Blood left within the thoracic cavity tends to form a stable clot that is not amenable to tube drainage and can progress to pneumonia and, worst case scenario, empyema. This is why we try to place chest tubes early when hemothorax is first identified. Additionally, we're starting to evaluate whether pleural irrigation at the time of chest tube placement or soon thereafter can help decrease rates of retained hemothorax and need for additional procedures. For retained hemothoraces, Video-assisted thoracoscopy can be performed with high success rates. Empyema occurs when there's an infection of the pleural space, which is diagnosed by positive pleural cultures or just frank purulence. This is treated with long-term antibiotics and pleural washout and drainage via VATS or a thoracotomy. VATS is typically used in earlier stages, and thoracotomy is used for later stage or failed initial therapy.
And what do you do about the patient who has a persistent air leak from his or her chest tube after suffering thoracic trauma?
A persistent air leak is one that lasts beyond 5 to 7 days. This is the point at which we begin to worry about a bronchopleural fistula. A true bronchopleural fistula is a centrally located communication between the pleural space and a lobar or segmental bronchus, which can happen with injury to major bronchi or following pulmonary resection, but this is overall pretty uncommon. Most post-traumatic air leaks result from communication between the lung parenchyma and the pleural space, and these can usually be managed with autologous blood pleurodesis, commercially available sealants, endobronchial one-way valves, or just resection.
With that, we are out of time. Thank you, Dr. Niziolek, so much for being with us today. We got through a ton of great information about chest trauma, though in some ways it feels like we only scratched the surface. As always, if you're looking to learn more, you can check out some of the literature we referenced in today's episode in the show notes, and a full review of chest trauma can be found in the Washington Manual of Surgery.
We are Drs. Paul Wise
and Jeff Blatnick,
senior editors of the Washington Manual of Surgery. We'd like to thank the residents and faculty of the Department of Surgery at Washington University Medicine, and we'd especially like to thank our associate editors for this edition, Drs. Catherine Caldwell, Ina Chen, Bradley Kushner, Martha Bucky McGilvray, and Jorge Zarate Rodriguez.
We hope that you enjoyed this episode of the Washington Manual of Surgery podcast. For more comprehensive information in a brief outline format, check out the print and digital version of the Washington Manual of Surgery, published by Wolters Kluwer Health and Lippincott Williams & Wilkins. Please search online for the Washington Manual of Surgery 9th edition to purchase your copy of the manual.
To learn more about the educational opportunities available in the Department of Surgery, please search General Surgery Residency at Washington University School of Medicine in St. Louis.